And now Dr. Yazan will speak about hybrid management for aortic arch regions with single branch device.
Thank you very much. I'm going to talk about endovascular management, hybrid management of aortic arch lesions. Shukran. These are my disclosures. In general, just like any other part of the aorta, endovascular and hybrid management aims to decrease the morbidity and the mortality of the treatment and open surgical repair. Open aortic arch replacement has been well described, and the outcomes have been analyzed in the literature over the last several years. The pooled estimates of outcomes are mortality of around 5% in busy centers, with a stroke rate of somewhere between 3 to 5%. This was also analyzed in the STS US registry, where almost 1,000 open arch repairs were looked at, with a mortality rate of around 6.7% and also a stroke rate of around 7%. But it is still considered the gold standard treatment for pathologies in the aortic arch. Endovascular aortic arch repair has been described and has been looked at for the last 2 decades. The first case was from Japan in 1999 with three branches from an endograft, and this was successfully implanted. We do not have data about the long-term follow-up of that case. And Tim Shooter described in 2003 a single branch device with a debranching of the carotid artery and the left subclavian artery to accommodate hybrid repair of the aortic arch. Now, currently in clinical trials and in Europe, we have dual and triple branch aortic stent grafts, and the multi-center experiences have been described with decent mortality rates and stroke rates. In the United States, we only have a dual branch device in a clinical trial, and this is the Terumo device. And interestingly, it was just withdrawn from the clinical trial recently due to high incidence of stroke. It's a dual branch device requiring a left carotid to subclavian bypass and antegrade branches to both carotid arteries by retrograde axis of both common carotid arteries. This is one of the cases where an aortic arch aneurysm was treated with, Sorry, the video is not playing. This was supposed to show an endovascular treatment with a dual branch device. Okay, but the topic of this presentation is on single branch devices, and the reason a single branch device is proposed is because it can be done without much customization as an off-the-shelf device, using the same device to treat zone 0, zone 1, and zone 2, and it is therefore more feasible to commercialize and adopt in different institutions. Single branch devices currently that exist are a Gore single branch device, Gore TBE, and another device, Endospan, which is currently in the clinical trial phase in the United States, which is Endospan Nexus device. So what we did in order to analyze the percentage of patients who would be candidates for a hybrid repair with a single branch device in the aortic arch, we looked at the inclusion criteria for 2 devices that were in clinical trial at that time, the Gore TBE device as well as a Medtronic Mona Lisa device, which was ultimately not continued and not commercialized as the clinical trial was suspended. again, due to stroke rate. But we looked at the inclusion criteria to see how many of the patients that we performed open surgical repair of the aortic arch in our institution would fit for a single branch device in the aortic arch with carotid, and carotid subclavian bypasses. The GORE TBE device has an integrated inner portal that allows anchoring the modular side branch component. It requires access from the brachial artery and the femoral artery, so a through and through access from the brachial and femoral, and the branch is oriented in a retrograde fashion. So whether the branch is going to the subclavian or the carotid or the innominate artery, it perfuses in a retrograde fashion from the device. All the videos are not showing, and I apologize. So what we looked at, we divided the aortic arch zones as according to the classic nomenclature, and we had we looked at a 3-year period in our institution of patients who had open aortic arch repair, and included all patients with PAUs, aortic aneurysms, or chronic dissections, or even type 1A dissection from type 1A endoleaks from prior TVARs, but excluded emergent repairs and acute type A dissections or repairs that required aortic root replacement. And we looked at CT scan images of these patients who had undergone open repair and analyzed them to see what their candidacy would have been for endovascular repair with a single arch device, with a single branch device. So in order for a patient to be considered eligible for that device, they should have an adequate proximal seal zone in the ascending aorta or in the aortic arch between 16 and 48 millimeters. That single branch that will be accommodated by the device should have an adequate diameter, not be aneurysmal or diseased, and should not be involved in the disease process in the aortic arch. The proximal length of the seal zone should be around 20 millimeters when we are sealing in the aortic arch. I'm sorry about the figures. None of the pictures are showing here. And if we are going to seal in the ascending aorta, we said that the proximal seal length should be 40 millimeters. So what we had is around 50 patients, and we have around 43% of them had prior open ascending repair, and 5 of them had prior TVARs. We noticed that 43% of those patients who had open repair at our institution would have been candidates for neck debranching and a single branch device in the aortic arch. 2 of these would have been treated with a zone 2 deployment. Only 1 would have benefited from a zone 1 deployment. Again, sorry about the video. And 37% would have benefited from a zone 0 deployment, which would have required the carotid bypass and the carotid subclavian bypass. The reasons patients were not considered to be eligible for zone 1 or zone 2 deployment were due to the presence of proximal aortic arch disease that would have required extension into zone 0. And in zone 0, those patients who were not considered to be eligible for treatment with the device were these patients who had abnormalities in the innominate artery that would have made deployment of the innominate artery branch not possible, or had dissection in the innominate artery, or if they had a short length of the innominate artery due to early bifurcation, which would have made a single branch device not possible. A Nexus device would have been a different kind of device to be used in those scenarios, and the Nexus device is a device where that requires a femoral and axillary axis, and the device is interestingly deployed directly into the innominate artery with the proximal end of the device ending in the innominate artery and the distal end of the device ending in the distal aortic arch. And then you connect it with a separate component that extends into the ascending aorta. So the Nexus extended our zone 0 eligibility by accommodating slightly larger innominate artery diameters and slightly shorter innominate artery lengths. But regardless, in general, the eligibility for a hybrid repair of the aortic arch is around 40 to 50% of the cases that currently are undergoing open elective repair of the aortic arch. So again, this eligibility for this technique is promising. There is still a predominant role for open surgery in the aortic arch, largely because the stroke risk is still ill-defined in endovascular and hybrid repairs, and the long-term performance of these devices is still to be determined. In addition, arch disease is usually still continuous with the ascending aortic pathology, and future development of any aortic arch device should include also devices that would address the ascending aortic component. And again, I'd remind you of this case that we presented here last year of including the aortic, ascending aorta as well as the aortic root with coronary fenestrations. Thank you very much.